Cervical cancer is the fourth most common cancer in women. In 2022, an estimated 660,000 women were diagnosed with cervical cancer worldwide, and about 350,000 women died from the disease. Cervical cancer develops in a woman's cervix, the entrance to the uterus from the vagina. With a comprehensive approach to prevention, screening, and treatment, cervical cancer can be eliminated as a public health problem within a generation. Well, I have joining me the former Minister of Health, Professor Isaac Adewole, with us in the studio to discuss the best ways to eliminate cervical cancer. Good morning. Thank you for joining us on TVC Breakfast.
Good morning. It's my delight to be here.
Right. This figure that we are having here is actually, 2022, 660,000 women were diagnosed and about 350,000 women died. What are the current figures that we're up against, and how would you assess Nigeria's strategy in eliminating this?
Thank you so much. The current figures actually will be about a year behind whatever is announced. And so for Nigeria, we're looking at about 12,000 women with cervical cancer diagnosed every year, and about 8,000 of them die from the disease. Globally, we say every 2 minutes, a woman dies from cervical cancer. But in Nigeria, every hour, a woman dies from cervical cancer.
Wow. And this, it's very alarming, looking at the fact that we have a high rate of, cancer in Nigeria at this point. Some have attributed this to environment, genes, and all of that. Talk to us about the major cause of this, and perhaps what the average woman should look into as a form of prevention.
Thank you so much. I think the level of knowledge as of today indicates clearly that the cause of cervical cancer is a virus. And that virus is called human papillomavirus, which likely is transmitted sexually. And once a woman is sexually active, within 2 years of sexual debut, there is acquisition of human papillomavirus. But then the body's immune system clears this virus over a period of time. But then a few are unable to clear the virus. And among the few, some will develop lesions that we consider to be pre-malignant, occurring before the onset of cancer, and then rather few again will go on to develop cervical cancer. So hence, we describe cervical cancer as a rare complication of a common sexually transmitted infection.
Okay, so talking about the elimination strategy employed globally, how does this align with Nigeria's cancer control plan and health priorities?
Well, the beauty of it is in 2018, looking and relying on the body of knowledge that we have, the WHO Director General, Tedros Ghebreyesus, announced publicly that the world is at the threshold of eliminating cervical cancer, and therefore sent a resolution to the World Health Assembly, which was approved in 2020. And for the first time in the history of the world, the entire world is committed to eliminating a cancer. And that's how we got about it. And then we're happy to say that Nigeria took the bull by the horn and established a national task force, which I'm fortunate to chair, to eliminate cervical cancer. And that's where we are. The strategies are broad. One is we try to integrate prevention with early detection of cervical cancer, and then putting in place structures for treating those who already have cervical cancer.
And we've seen an increase, in awareness and all of that on cervical cancer and all other forms of cancer, on the human papillomavirus also. However, we know that in some hospitals, some of these vaccines and all of that are usually free. I don't know about if it's free in public hospitals, actually, but in some other hospitals, it is actually free. Talk to us about the major steps that you took as a former Minister of Health in this country to ensure that we should have it to the barest minimum.
Well, let me declare up front that the decision to bring the vaccine into the country started when I was Minister of Health. But we were largely constrained by two factors. One, the absence of the vaccine and the amount of vaccine that Nigeria will require. If we look at it with a population of 200 million, we estimate that we will need to vaccinate close to 60 million people in Nigeria if we really want to be on board. But then, and the vaccine was also in short supply because the initial strategy was to give 3 doses of the vaccine. And about 15 years ago, I and my colleagues actually wrote a paper using modeling to say that with one single shot of this vaccine, combined with screening, we could be on the threshold to eliminate, on the threshold to elimination. This paper was not accepted because the world felt this was out of it. But it's interesting to know that that single dose vaccination now is what the world has accepted. And so we have started in Nigeria, and I am proud to say that Nigeria has actually conducted an introductory vaccination program, the largest of its type in the world, where we vaccinated close to 12.5 million girls aged 9 to 14 over a 9-month period. It's unprecedented, and no country has ever done that in the world.
How did Nigeria get to gather people or vaccinate people, that amount of people, without having some pushbacks?
Well, one is good planning, good logistics, investment, and international collaboration. But we had pushback because I can tell you that where we are today, Lagos State had the lowest acceptance rate. Lagos had, in fact, an acceptance rate of 36% compared to 98% in Taraba. So there was feedback in about 3 states where we think we did not do well enough, and that would be Lagos, that would be Enugu and Ogun. But in other states, it was a superb performance.
Well, what do you think was the cause of that in those 3 states?
Well, there's a lot of reaction from anti-vax group, social media reactions, rumors against this vaccine. There is anti-fertility, which is not true, and the fear of complications, which is also likely unfounded. Having vaccinated 12.5 million girls, we can tell the whole world that we did not record any major complication in Nigeria.
So how did all of this misinformation come about? How did all this come about?
Well, it's not peculiar to Nigeria. It's a global event where some people deliberately do not like vaccines, and they peddle rumor against vaccines. To me, it's one of the issues that we have to deal with, particularly in the health sector, where there's a trust deficit. People do not trust our government. They did not trust things that come from outside Nigeria. And so those likely contribute to this effort. And then with social media, anybody with a cell phone, with access to internet, can peddle any rumor and tell the whole world a false narrative.
Yes. So what steps were taken to address all of this? Because Nigeria is still going to vaccinate more people, more girls
certainly.
in the long run.
Certainly.
What steps were taken and what steps is the government still taking to address?
Well, it is one of the issues we discussed at our ongoing retreat. The task force is having a retreat, and we are looking at the lessons that we learned from that introductory effort. One is that we need to do more communication. We need to gain entry into the community. We need to stay ahead, and we need to build robust partnership. One of which we are doing now with you, because this is a platform that we need to really scale up and let people know that this vaccine has no side effect, and that when you give it, you will likely prevent cervical cancer.
And it's very shocking that, the level of acceptance, you mentioned that we had a high level of acceptance in Taraba as against
98%.
Lagos. And then we expect that possibly places that are, very open, more of a business hub and all of that, so to speak, especially when you consider the increasing number of out-of-school children in northern Nigeria, there will be a low acceptance of that in that region. But aside from that, let's talk about the symptoms. So many persons may not be able to identify symptoms, and we still have the issue of self-diagnosis. We still have online doctors. We have all of those who decide to manage their symptoms because of trust deficit, like you said?
Well, excuse me. The thing about cervical cancer is that many of us love cervical cancer because it takes about 10 to 20 years to develop.
Wow.
That gives us enough time to ambush this disease along the path to developing cervical cancer. And that's where screening comes in. But then also, at the last survey, only 13% of Nigerians have ever been screened. So there are quite a number of people who have never been screened for quite a number of reasons. At our retreat yesterday, we were talking about reference to private part, the fact that how women don't want outsiders to look at them. And so the way we treat our genitalia is different from how we should do it in order to keep it healthy. But then, one of the things we've noticed is that when you miss the vaccination, you miss screening, and then the disease are setting in the early stages, the beauty of it is that for cervical cancer, we can even cure when we pick it early. But then, unfortunately, about 80% of our women come in late, simply because the earlier symptoms or earliest symptoms is bleeding during sexual intercourse. And that creates a problem. Many women, when they bleed after sexual intercourse, stay away from the man, accusing the man of traumatizing them, not recognizing the fact that there must have been a problem with the cervix. And when they move away from the man, the bleeding stops. And that will give them a false sense of hope. And then over the next 2 to 3 years, this disease will now grow to a stage where we can no longer offer a cure. So we will advise women, one, do screening. For now, we recommend screening every 3 years. But once vaccination sets in, we will recommend it once in 10 years. But then if you miss it, if you have a contact bleeding during sexual intercourse, please visit your doctor. If you are not happy, go for a second opinion. And then, very importantly, is insist on being examined. Because sometimes, in the studies that we did, we call it the WAC study, African Women Against Cervical Cancer, in Ghana, Nigeria, and South Africa, the average woman with cervical cancer must have seen 3 to 4 doctors who did not make the right diagnosis. So there's also a need to educate health professionals to get it right, make sure they diagnose the woman, take a sample of the cervix and send it to the lab for analysis. And that will confirm cervical cancer. But once it's confirmed, we treat, we can, in the early stages, we are sure of cure.
All right, so looking at policy and advocacy, what kind of policies and legislative measures can be put in place to help promote and support this global policy to eliminate cervical cancer?
Well, the thing is to reach out. In terms of policy, we cannot force people to go for checkup, but we can encourage them through education, improve the awareness, and that's what we're doing. And we intend to do this on a global scale. We actually, one of the subcommittees that we have within the task force is one on communication and community engagement. We need to let the people know about this disease and that almost all these deaths are preventable. That's the thing about cervical cancer. Almost all of them. The 8,000 women that will die, the 12,000 new cases every year are largely preventable through a multitude of approaches, which will include vaccination, which will include screening and treatment, especially when we pick them early. But what is also important is that we also need to encourage policymakers. We need to invest. We also need to encourage healthcare providers, train them young, and it doesn't have to be doctors, it could be nurses, health attendants. Just look at the cervix. God has really given us an opportunity. The cervix is not hidden. It's not the colon, it's not the ovary, it's not something we cannot see. By putting in an instrument to look at the cervix, we can see the cervix.
All right, so in a country where you talked about going for regular health checks, but we have seen that health care is very expensive here. How do we go about this when we have people in rural communities or even in urban communities who cannot afford healthcare.
Well, interestingly, it doesn't cost much to prevent cervical cancer. And one of the strategies we are recommending and will put in place is really downscaling to the primary care center. Okay. That is the health facility nearest to you. And I did mention that we will train nurses, we will train community health attendants to look at the cervix. So to me, with appropriate investment, education, and scale up, we will make sure that you can approach a facility next to you. And once we vaccinate a large number of people, we're there.
Do we also encourage local methods in addressing cervical cancer? I'm sure you understand what I'm talking about.
No, not yet. I think you should educate me.
Well, a lot of people, when they are ill, they go and take local herbs. And so because of the fact that health is expensive, healthcare is expensive here, many people might resort to using local herbs to address issues of cervical cancer and all of that. Do we go that route?
Well, I wouldn't recommend that for obvious reasons. We have an effective vaccine. And studies done, even from Scotland, indicated that in communities that have been vaccinated, they've not recorded a single case of cervical cancer over the years. So we have instruments to use, so there's no point. Where you are not in doubt, please go for the right thing. Okay. And I can assure you that we're almost there.
All right, so let's talk about how ready our healthcare system is to actually address, this raging figure. You mentioned earlier about the average person that presents with cervical cancer may have paid a visit to 2 or 3 doctors thereabout, and they were misdiagnosed. So we also have a problem of diagnosis at this time. Talk to us about how we can manage this. Amid the whole, we have a lot of doctors going outside the country. We have raging figures of cervical cancer amidst other cancers in the country.
Well, it's a complex issue. Let's be honest, anybody can make a mistake when it comes to getting it right. I think when we demystify the female genital tract, I think the issue of not wanting to examine the woman will be put behind us. A couple of days ago, I watched a video online, one of these. Sometimes you want to amuse yourself. Someone will send you on a platform, you get a video, and it had to do with a doctor who wanted to examine a lady. I don't know if you saw it. And the man was there and would not allow the man to examine the woman. Interestingly, the doctor had a stethoscope and wanted to place it on the chest. The man said no. Took the chest stethoscope and was putting it. Even to take temperature, the man said no. Took the thermometer from the doctor. That's the type of situation that we have. But then, what was missing was that there was no chaperone.
Okay.
So there ought to have been a chaperone, a female, to be there when you examine somebody of the opposite gender. So I think it's important. We will adopt a multitude of approaches that will take into consideration our peculiarity. We are also training. We are not only giving vaccines, we are not only going to train people to screen and treat early cancers or lesions before cancer. We will also train people to treat cancer. And the country is also scaling up, setting up centers of excellence to manage cancers. Cancer is not just what anybody can manage anywhere. Once it's cancer, it should be managed in a specialized center.
All right, you earlier mentioned about the fact that 3 states recorded low turnout in 3 states, and you also talked about the reasons. What were the reasons you achieved such a high turnout in states like Taraba that you mentioned?
Yeah, I did mention that adequate preparation, good community entry are things that helped us. In some of the communities, we will go through the emir, the religious leader, the traditional leader, and so on. These are people respected by the community. When you go in through such routes, the people are likely to accept vaccination. But if you just walked in, they are going to treat you with suspect.
And at this time where we have, a whole lot of, would I call them accidental doctors, so many persons now begin to diagnose and all of that. How do we address the issue of quacks in the industry? I'm also staying on that misdiagnosis because I think it is an issue that should be addressed in order to get an accurate figure of those that are currently presenting with cervical cancer. How do we address online clinics? We have a lot of them. We have doctors. We have people who diagnose cancer, misdiagnose cancer for malaria and other things. How is this a problem in getting the correct figures?
Well, it's again a global problem. I'm sure you heard of the doctor, I think in US, who was recently convicted for making a false diagnosis of cancer and was actually putting them on anti-cancer drugs. And you cannot really eliminate things like that in any profession. People do it for psychological reasons. Some of them have mental disturbances and so on. But what we do is to improve our training. As you might be aware, in our medical schools, we're changing the curriculum from the old system to a problem-based integrated learning approach, where as you go on, we're exposing you to common diseases and the causes and how to manage them, to detect them. I think with improved curriculum, improved teaching methods and exposure, we will get over this. And then the Medical and Dental Council is also empowered to sanction as appropriate.
I think stigmatization is also another issue.
Oh, certainly.
How many persons would actually want to discuss with their neighbor what they're actually going through? And this also delays, screening and all of that. How are we addressing that? And I'm also interested in if cervical cancer is actually, related to other diseases. Does it perhaps expose you to other diseases? Does it have any relation to HIV/AIDS and others?
Well, it seems to have done a lot of homework with cervical cancer. You should actually be on our side. I think the greatest disease that is associated with cervical cancer is HIV infection. And those who are HIV infected are exposed, or in fact, 6 times at risk of developing cervical cancer compared to those who are HIV negative. So HIV is a major issue. Right. And that's why we're also focusing, and for quite a number of years in the past, screening for cervical cancer is a major part of our HIV treatment and care program. Right. So we're looking into that to make sure that nothing is missed.
And also stigmatization.
Stigmatization, we're also trying to, when we were being trained, one of the things our teachers will tell us that, it's common among those who are sexually active, common among those with multiple sexual partners. We're trying to de-emphasize that it is not the number of sexual partners. It is, those ones are just indicators for risk. And so let us de-emphasize it so that anybody with cervical cancer will not have a sense of guilt to say, maybe it's because of what I did in the past. I will not want to show up. And then that there's really nothing we should demystify the female genital tract. And it belongs to the woman. Even though it's a passage for bringing us to this world, that passage can become afflicted and should be taken care of.
Are we on track to eliminating cervical cancer by 2030?
Yes and no.
Okay.
With what we put in place, we should be able to get there. But we are just starting. With the support we have and quite a number of things that have taken place in Nigeria, I think we'll get there. Many of us are optimists, incurable optimists. Nigeria has put in place a scheme that will enable you to notify every case of cancer. Good, that will give us good data that you're asking for. Secondly, this country set up a National Institute for Cancer Treatment and Research, NICRAT, good for us. The Federal Ministry of Health put forward a directive that nobody should manage a cancer patient without that patient being screened by a multidisciplinary tumor board, which is what will happen anywhere in the world. No single doctor will sit anywhere and treat a cancer patient. So that means that patient has to go through a specialized center. And then we're scaling up treatment centers. And so I think we will get there. All we need to do is try and scale up here and there. And Nigeria. We didn't start vaccination early, but when we started big. Many of us say that when Nigeria says we're doing a pilot, that pilot is big. We vaccinated 12.5 million women, almost the population of Rwanda, in 9 months in Nigeria. That shows what you are capable of.
Right. But is all of this applicable in the rural areas where the health facilities are not enough for a full community? And how do we drive this initiative in those areas so that we can achieve more?
Well, I made mention of ensuring that we do screening and even vaccination in primary care center. That's the health center that is closest to people. And once we do that, I think we're there.
But some of these primary health centers in some villages are quite far from some people. How do we address the gaps there? No.
The way we situated, even when we were in office, we had a program of making sure we made 10,000 PCs functional. At the end of 4 years, we've done about 4,000. I can tell you under the present coordinating Minister of Health, they are scaling up. In other words, that will be enough. And all we want to do is make sure you are not too far from a primary care center. And we will hit it right.
Right. So screening, diagnosis, and let's go to treatment. Cancer has a possibility of spreading, and I don't know if it can actually be managed with the vaccine, even if it has spread. Is that also possible? And then the cost of treatment, as with other cancers, how is our insurance doing?
Well, the vaccine is a preventive vaccine.
Right.
It doesn't cure anybody with either HPV infection or with cancer. No. Researches are ongoing globally to look for a therapeutic vaccine, but we have none yet. For those with cancer, we are also, which I should have mentioned as one of the positive developments in Nigeria, the federal government set up a cancer health fund to take care of people with cervical cancer, breast cancer, and prostate cancer. So those three are being taken care of. And so that to me, and then the National Health Insurance Agency is also stepping in to make sure that additional support is provided. So there is also support for those who could not afford the cost of care.
Okay. All right. I think this is a fine place to leave the conversation for today. This figure, we're hoping we have a reduction, of course, with your efforts in addressing this. Former Minister of Health, Professor Isaac Adewole, thank you for joining us.
Vice Chancellor at the University of Ibadan.
It's so good to meet your Vice Chancellor on set today.
Yes.
Thank you so
for
much.
joining us.
Thank you. It's a pleasure.